It's another beautiful day and a warm welcome to another episode of Today's Parent, where we connect you with experts and provide you with information to make your parenting journey a bit more easier. I'm your host, Christian Kasina. In today's episode, we have Dr. Kireki. He is a fertility specialist and a beloved gynecologist in this town and in Kenya. You've asked a lot of questions that you've sent to us when it comes to fertility, and we want to answer those questions right back to you so you can be informed when it comes to matters fertility. Welcome to today's show. Dr. Harry, it's a pleasure to have you.
Thank you very much, Christina, for inviting me once again to the studio. It's always a pleasure.
Always a pleasure
to talk to you and to talk to our viewers.
Always a pleasure. What we are going to do today, we are going to have a Q&A, the questions that our viewers have sent, so you can answer them one by one. And I know a lot of the questions have been sent anonymously. I don't have most of the names, but then I know just asking the question will be able to answer the question to many viewers who could be asking the same question.
No problem at all.
The first question, Dr. Kireki, somebody is asking, what can I do? I have been trying to get pregnant for 1 year.
Yes.
I am 22, and my period is irregular, and I don't use any contraceptives.
Okay, that's a problem which quite a number of women are actually battling with. She said she's 22.
Yes.
Her periods are irregular, and she's been having unprotected intercourse, and she's not taking any contraceptive. Yeah. Now, I think the first thing we need to know is the definition of infertility, and actually she fits that definition properly, because she's been having regular intercourse, no contraception, and a year has passed, and there is nothing to show for the intercourse that they've been having. There is no conception. So the first thing I think she needs to do, being 22, she has an advantage. Age is not a factor.
Right.
So we need to have a look at her. We need to do a blood test to look at her hormones, because if her periods are irregular, there could be different reasons for her periods being irregular.
Okay.
There could be a hormonal imbalance. There could be a problem with her thyroid hormones. Could be a problem with her prolactin. Could be a problem with polycystic ovarian syndrome, etc., etc. So there are quite a number of reasons why the periods can be irregular. That's number one. Number two, we also need to look at her partner as well, because you may be okay, the lady may be okay, but the partner may not be okay.
Yeah.
So a semen sample is very important. And then obviously we need to have a look at her tubes as well, because if her tubes are blocked or there is an issue with the tubes, then obviously she may have a problem in getting pregnant, even though she's been having regular intercourse for a year, no contraception, and so on and so forth. So I think her first port of call is to see a specialist, and then we take her through the basic procedures, and then we find out what the problem is, and then we can help her.
Okay. And for anybody else, of course, who's going through the same, the best would be to see a specialist.
Absolutely. Absolutely.
All right. The second question is most likely from a civil servant.
Yes.
Her question is, does NHIF still cover IVF for civil servants?
I think as per, today is when? Today is Tuesday.
Today is Tuesday.
Today, yeah. As per last week on Monday when I was in clinic, NHIF was still covering for IVF treatment in civil servants. So what I have noticed is that some of the what we call pre-authorizations that we write to them, they may reject, either because either the job group of the civil servant, or for other reasons altogether.
So it also depends with the age group of the civil servant.
The job group.
The
job group. And the other things which we are not very clear about is whether parastatals, workers of parastatal organizations, are actually civil servants. So theoretically, we may think that they are civil servants, but they may have a different contract signed with the NHIF. So that one we may need to have a look at it. But when it comes to civil servants per se, patients who work in the ministry or their husbands, not armed, but National Police Service, and so on, NHIF is still covering for that.
And normally the coverage is 100%?
Usually it is 100%.
100%.
Absolutely, yeah.
Right. Our third question. I had a miscarriage in June, and now there's some whitish small particles coming out from my vagina.
Yes.
What is the cause, please?
First of all, our sympathies for her having a miscarriage, because a miscarriage at any time in a pregnancy, or even premature delivery, or even a death of a baby, whether inside the mother's womb or even after delivery, is a devastating and traumatic experience.
Absolutely.
So our sympathies to this lady who lost her pregnancy. Now, what we need to find out is two things. Number one, was she given any medications to sort of make the miscarriage come out or the pregnancy come out?
Okay.
Or she had her womb cleaned, in other words, what you call D&C or D&E.
Yeah.
And what happened afterwards? Are her periods normal? Are they regular? And if they are not, then we need to have a look at that. Now, when it comes to those white particles which are coming out of her private parts, as she said, I think the first thing we may need to find out is, is there any itching or there's no itching? Is there any smell coming from her private parts? What kind of smell? etc, etc. These are all very important in us to be able to actually diagnose what the problem is and help her. So I would suggest that she sees her gynecologist as soon as possible.
Right.
She has what we call a vaginal examination, a speculum examination done, and then she answers these questions which I've mentioned, and then we can be able to help her. Yes.
What worries me about her question is, she doesn't mention that it's a discharge, that particles. That's very different from the usual problems that women have.
Sometimes there can be cuddly particles, whitish cuddly particles, which is highly suggestive of a yeast infection, candida infection. But we don't want to assume. So it is good for her to go and see her gynecologist. The gynecologist will have a look inside the vagina, and then we take it from there.
Right. All right. Moving on to the next question. Somebody is asking from Nakuru. Actually, Carol from Nakuru is asking, can the blood group O positive be a cause for miscarriage?
Okay.
First of all, taking it from blood groups, does it have anything to do with miscarriages?
Yes and no.
Okay.
Yes and no. Now, thank you, Carol from Nakuru, for asking this question, because it's an important question. Because once ladies get married and they get pregnant, the first thing that we want to do is to know when the last monthly period was, when it started. So we want to establish where this pregnancy is, how many of these gestational sacs are there, and whether there is a baby there and there is a heartbeat, and so on and so forth. Once we've done this, then the next thing that we want to do is to do some tests. And one of the mandatory tests that we do is a blood group. And the blood group is for the lady and for the husband as well. Why are we doing this? We are doing this because if, for instance, the lady is O positive, as she said, and the husband is another group which is negative, or the other way around, we can have a problem. Why? Because we have what is called isoimmunization, a long name.
Isoimmunization,
yes. What happens is that if, let's say, the lady is negative and the husband is positive, sometimes the baby can carry the husband's, the partner's blood group. And sometimes a bit of that blood can actually enter the circulation of the mother. And what happens is that because blood is basically protein, and our bodies have what you call an immune system, what protects us from infections, etc, etc. Actually, the immune system will actually notice that there is some foreign particles here. There's some foreign protein. So what they will do is that they will produce what we call antibodies. And these antibodies will be against that foreign protein which is circulating in the blood, and which the baby also has. So it will also have a negative effect on the baby as well.
Wow.
Thankfully, it doesn't happen very often. It happens in about maybe 2 or 3% of the pregnancies that we see where isoimmunization takes place. Now, if we have a patient who has a negative blood group, so we do a blood test. Actually, we do a series of blood tests, what we call a indirect Coombs test, to see whether there are actually antibodies circulating in the system. And if they are there, what is the level of the antibodies.
Okay.
Because then this gives us a picture about what is happening.
Okay.
And then later on, we have to do a series of blood of scans to see how the baby is developing. Because with the isoimmunization, it can actually affect the baby.
In what way?
The baby can start having what we call hydrops, that is fluid, which is not supposed to be there.
Okay.
Fluid around the chest, fluid around the heart. It can actually even go just below the skin, and so on and so forth.
That must be dangerous.
That is extreme. It's extreme cases.
Okay.
That is why it is very important if we have negative blood group and a positive blood group. Your doctor needs to do these tests right at the beginning. Now, if we do find out that yes, there is a problem and this level of these antibodies is elevated, then we need the pregnant lady will need very specialized care. Sometimes you can actually do even transfusion in the womb. Okay. And now, when they deliver, that is also something else, because usually this doesn't happen in the first pregnancy. It can happen in subsequent pregnancies.
Okay.
So once a lady who is negative, has a negative blood group, delivers, we need to get cord blood from the umbilical cord, and we test it. Plus the mother's blood, and then we give them what is called immunoglobulin anti-D. This now we introduce. What basically does, it sensitizes the body such that the next time there is a baby who has a different blood group from the mother, the immune system will have actually know this one, we know it, so we don't have to fight against it.
Right.
So we sort of sensitize the body against future pregnancy.
We're going to take a short break, and then when you come back, we'll take more questions, and then you can educate our viewers.
No problem at all.
In today's episode, we have Dr. Kireki, who's a gynecologist and a leading fertility specialist here in Nairobi and in Kenya. He's taking your questions, and we are privileged to have him here. We thank you so much for sending your questions so far. He's answered most of them, and we're going to go to our second part when we come after the break and hear more from him. Don't go anywhere. Welcome back to today's episode of Today's Parent, where we have Dr. Kireki, a leading fertility specialist and gynecologist, who's taking your Q&A. Dr. We are back from the break.
Thank
and
you.
Moving on to the next question.
Yes.
This is a question from Jerry from Kasarani.
Yeah.
She says, I've got a friend, she's asking on behalf of a friend who's having issues with cyst growth and pus from the cyst. She's 33 and has been deflowered just recently after her marriage. This is a lot of information.
I'm telling you.
But anyway. So I'll go back to the deflowered part.
Okay.
Deflowered just recently after her marriage.
That's right.
2 years ago. Does abstaining for a long time bring cyst growth?
Okay. Now, I think there's a bit of information which we are lacking there. And some information is not very clear. Because when you talk about cysts, a cyst is basically a structure which has some content in it. And this content can vary.
Yeah.
It can be clear fluid, what we call, and again, it depends on where it is. So here we say, let's say we talk about ovarian cysts, we can talk about clear fluid in a cyst, a structure which is 2.5 centimeters or more. So we have a normal or a simple cyst.
Okay.
They can have some blood in it, fresh blood in it, what we call a hemorrhagic cyst. We can have some old blood in it, what we call an endometriotic cyst.
Right.
Now, this cyst can actually have some tissue as well. You may have some teeth there, some hair, some oil.
Did you say teeth?
Yes, teeth.
Real teeth?
Real teeth. What we call a dermoid cyst. We may have some mucus-like content, what we call a mucinous cyst, and so on and so forth.
Okay.
So she doesn't say exactly where this cyst is. So let us assume that now we can go further down, and in the female anatomy, there is a place whereby we have what we call a Bartholin cyst.
Right.
There is an area which normally secretes some discharge, some fluid, which actually does help in intercourse. Now, if that is blocked by whatever means, whether it is because of bacteria or whatever it is, it causes an infection, a retention of that fluid, and that leads to an infection, what you call a Bartholin cyst. So maybe what she's talking about a cyst with some pus and whatever it is, highly suggests that it could be a Bartholin cyst.
Okay.
That is what I think. But she doesn't say exactly where it is.
Yeah.
That is just an assumption, because if you have some pus in the abdomen, because that is also possible, usually because of an infection, or you've had surgery and you've had secondary infection and so on and so forth, the symptoms are horrible. You may have very high temperatures, you may have your pulse goes very high, your blood pressure starts dropping. It is actually life-threatening.
Okay.
So in that case, I think I would put my money on the Bartholin cyst.
Right.
So the other question is whether abstaining for a long time.
Yeah, because her friend is 33 and recently got married.
Yes. So abstaining for a long time can lead to cysts? I don't think so.
Okay.
No, it doesn't lead to cysts.
Okay.
A cyst can be in that area that I mentioned, can be because of an infection and not abstaining from intercourse.
Okay.
Yeah.
In your practice as a gynecologist, are there any side effects of abstaining for too long or getting married what is considered late 33 and beyond?
Are there any side effects?
If at all?
I'm not very sure.
Not even 33.
But
why am I saying 33?
I don't know why you picked on that.
That's like in later stages.
Later stages.
Yes.
Because we have ladies who get married at 35, sometimes at 40, and so on. I think what may be not really a side effect would be, I mean, if you get married at 40 and you want to have a baby, that can be a problem. Adjusting to that, sexual life can also be a bit of an issue, and so on. But is there a direct cause effect? No. I don't think so.
Okay. All right. Let's move on to the next question. There's a lady asking, she took P2 in March.
That's right.
And now she can't get pregnant, in her opinion.
Yes. I think, you know what, Christine? I think maybe one day we'll just talk about contraception, just as a different topic altogether. But addressing her issue that she took an emergency pill in March. Was it in March or in May? In March. In March. In March. And basically what is in the emergency pill is a slightly higher dose of hormones, which basically are supposed to stop any pregnancy, any embryo from implanting. Now, the thing, and I think this is a caution to our viewers, an emergency is something that happens once. So it can't be an emergency every weekend. So you take an emergency pill every weekend. No, it is not. It is not proper, and again, it is dangerous to your body. So if you're taking emergency pills every so often, it actually is deleterious to your health.
Why is it dangerous?
Because of the high dose of hormones.
Right.
And then it causes havoc with your cycle, causes havoc with your periods, etc., etc. Okay. So it should be an emergency. It is once, maybe once a year, maybe twice a year, but not every week or every month, for that matter. Now, she's been trying to get pregnant after she took the emergency pill. What we don't know is that are her periods there? Have they started after the emergency pill? Because normally what happens with the emergency pill, when you take it, you have a period after a very short time. So she doesn't tell us that. So we need a little bit more information in order for us to be able to help her.
Okay. Because then if it has such an adverse effect, eventually if it's abused, why is it not regulated?
Well, there are so many things which need to be regulated. I mean, you start with antibiotics, for instance. That's another You also need to be regulated, highly regulated. I mean, in Kenya, you can buy practically anything over the counter. So long as you pay the price for it, which should not be the case. There are medications which should and must be regulated. But this is the way we are. I think we need to change, and hopefully we will change with time. That would be a good thing. Yes.
Next question. This lady is trying to get a child but lacks finances. I think the issue here is an issue of finances. Yes. Is there a way to then get a child access IVF and these other forms of treatment in a cheaper way, or you, I don't know, save and pay pole? Are there any options for people who can't afford?
I think number one, the issue of expense is something which it should be addressed in a structural, systemic manner. Right. Because basically what pushes up the prices are the medications that we use, the consumables that we use, and then obviously paying the personnel and so on and so forth. So if there was no, I don't know whether there is VAT for medications or not, that is something which the government should address. Number two, the consumables that we use, very expensive. We actually import everything. As opposed to countries like Egypt, whereby they have several, I think they have over 100 IVF centers, but of course...
They have over 100?
Over 100 IVF centers. But then the population is also a lot more.
I've never heard of anybody going to Egypt to try IVF.
I think it's because people don't know about it a lot.
Okay.
I think we are more conversant with South Africa and India, maybe, and so on. Now, that is one thing. Now, because of the demand that they have, they actually manufacture most of their consumables. They manufacture most of their drugs as well. So, and then the drugs are regulated. So it doesn't matter whether we are going to use drugs from company X or from company Y, the price is basically almost the same. So that makes it a lot easier, and it makes it more available for the patients as well. So can we do something like that in Kenya? I think we can. I mean, if we have the universal
health,
care, or so that should actually be part of it. Because when you look at it, actually in practical terms, 10%, 15% of the Kenyan population has issues with infertility, and we saw it's a big percentage. That's a big percentage. And we have the information from the last census. We are about 47.6 million. So if you take 10% of that, it's 4.76 million, which is a huge number. That's a big population. It's a huge number. So I think the problems should and must be addressed in a systematic, structural manner. Then it can be affordable. So in her case, I think she needs to talk to a center. She can come, we have a sit down, and then we look at how she can be able to try and finance her treatment. Yes.
All right. Moving on to the next question. The question is, what is a blighted ovum?
Very good question. The terminologies can be different. It can be a blighted ovum, it can be an empty sac, and so on and so forth. Actually, what it basically means is that when the sperm fertilizes the egg, there is what we call an exchange of chromosomes. And we know that this is responsible for this. For instance, the way you look, when you have your baby, you say, Imapuania Christine. That sort of thing. This height actually is in our family. This type of body is in our family. So all that information is actually encoded in the genes that we have. Now, some of these genes are actually responsible for creating the what you call the gestational sac. So you may have an embryo which has the genes for creating the embryo, for the gestational sac, but lack. So there is a defect in that embryo that we don't have the genes for creating actually the baby. So yes, there is implantation. Yes, there is a gestational sac, but unfortunately there is no baby. So that is why it is called an empty sac, or a blighted. Anything that is blighted is wrong, or it's bad.
There's an error in it.
It's an error in it. So that is why it's called a blighted ovum, which is a misnomer in itself, because we are not talking about the egg itself. We are talking about the embryo, which has been fertilized.
All right.
Yes.
Moving on to the next question. Contraceptive pills, do they delay conception?
By definition, the contraceptive pills,
that's the purpose.
That is the purpose.
Contraceptive.
That is the purpose. One of the purposes, because we can use contraceptive pills in other spheres when it comes to gynecology. So basically, what the contraceptive pills do, or basically contraception, hormonal contraception, basically what they do is that they stop the ovaries from working normally. And once they stop that, then the cycle is actually not there. And by doing that, the chances of getting pregnant are very low. It doesn't mean that by using contraceptive pills, you will not get pregnant, 100%. No, it's only the chances of you, if you take oral contraceptive pills regularly, almost the same time, the chances of one getting pregnant is about 1%. As opposed to other methods where the chances can be a little bit higher. So yes, by definition, contraceptive pills or methods are supposed to stop you from getting pregnant, or are supposed to help you to plan your pregnancies.
Okay. Moving on to the next one. I know we don't have a lot of time.
Yes.
So this possibly will be our last question. Is it possible to have an incomplete miscarriage and receive my period?
There are different types of miscarriages. And here we don't want to mix, because sometimes people talk about miscarriage and abortion, and they sort of intermix or use these terms together, which is not true. A miscarriage is different, and abortion is different. Now, a miscarriage is something that happens when there is a pregnancy, and that pregnancy, because of different reasons, it could be trauma, it could be because of an infection, it could be because of chronic diseases,
right.
etc., etc.
Right.
That pregnancy actually starts coming out on its own. There can be signs and symptoms for that. It can be, for instance, pain, low abdominal pain,
okay.
There can be bleeding, there can be spotting, and so on and so forth.
Okay.
So when you talk about an incomplete abortion, it means that that pregnancy was there. It started coming out. When we do a vaginal examination, we can actually see some of the tissue
right.
at the opening of the cervix, and then that's it. It means that some of that tissue has actually remained in the womb. Not a good thing. Why? Because if it remains there, the chances of infection are high, number one, and you can have this continuous bleeding or spotting also for some time, which is also not good. Now, so can you have an incomplete miscarriage and have a normal period? They don't go together. So there is something there that we don't know. So if she had an incomplete miscarriage, meaning that there was what we call retained products of conception in the womb, so she'll continue having some bleeding, some spotting, and so on and so forth, not because it is a period, but it because of the retained products of conception. So she needs to have a scan done to establish whether the lining is okay. And even if the scan is okay, theoretically, she needs to have her womb cleaned such that we can sort of restart her normal cycle, as it were.
All right, Dr. We've come to the end of our show today.
That was so soon.
I know we didn't have a lot of time, but it's always a pleasure to have you.
Thank you very much.
For any viewer who's watching and they'd like to connect with you, how can they get in touch?
They can get in touch with me. I have my clinic at 5th Avenue offices,
right.
Which is along Ngong Road. And the office is on the 3rd floor, suite number 314. And the number to the office is 0780 170 170. Very easy number to remember.
Thank you, Dr.
Karibu sana.
Thank you so much. That's the time we had today with Dr. Kireki. We thank you for viewing. If you have any more questions for Dr. Kireki, please send us an SMS on the number provided on your screen, and we'll see how we can get back to you or connect you with Dr. Kireki, or in another episode, see how we can answer your questions. So number one, thank you so much for your time. If you need to connect with Dr. Kireki, we provided you with the contacts. I have been your host, Christine Kasina. I hope you found this show to be very informative. We've been here at Little Cribs, the home of fun, exciting and durable kids furniture. If you're looking for parenting resources, head on to www.supermamas.co.ke, and we look forward to having you next time. Thank you for your time.